Hi, everyone, and welcome to today's webinar on evidence-based prescribing practices for behavioral health and diabetes. As folks are shuffling in, we'll just give another, about 30 seconds here, and then we'll go ahead and get started with today's program. Okay, and it looks like we've got a good quorum filing in here, so we're going to go ahead and get started. Again, welcome to today's webinar on evidence-based prescribing practices for behavioral health and diabetes. Just stand back here. So my name is Andrew Phillip, and I am the Senior Director of Clinical and Population Health here at the Primary Care Development Corporation. And if you're new to our series, PCDC, or Primary Care Development Corporation, is a certified and national nonprofit organization. We work with primary care, behavioral health, and related entities in a few different ways, primarily through capital investment to really transform the delivery of primary care and related entities like behavioral health. Also through advocating for the services needed to do that in our communities, and through transformation, including coaching, consultation, training, technical assistance, including this effort in partnership with the SAMHSA Center of Integrated Health Solutions. And on that note, it's important that you know that in this partnership webinar, the views that we'll be discussing, our opinions, do not necessarily reflect those of our federal government, including CMHS, the Substance Abuse and Mental Health Services Administration, or the United States Department of Health and Human Services, just that of ourselves and our presenters here. So today is, obviously it's part of a broader series that we're doing on really looking at moving beyond kind of just talking about the idea of integrating primary care and behavioral health, but really applying it in some new and novel ways. But also, we understand that this is a unique time that we're in. The effects of COVID-19 are being felt certainly by all of us here, but of course our patients, our communities, our nation, and our world. And so we wanted to acknowledge that. Dr. Gibson, our presenter, myself, the folks at the center and PCDC, we're all kind of thinking about this. And as we move forward as a healthcare system, trying to account for how do we talk about what's going on right now and what's on everyone's minds and what's impacting our health, but also consider how do we move forward with the work that needs to get done more broadly. And in thinking about it, we sort of came to the fact that we want to talk about COVID, but also right now, perhaps more than ever before, integrated care is critical. It's so important that at this very moment, we maximize the abilities of our teams, that everyone who's interacting in a clinical capacity with a patient has the most skills possible at their disposal to offer and deliver the most robust services to our patients. We need to do more at the point of care than we've ever been expected to do before. To this end, we know that there's been a lot of emails going out on all sorts of different listservs between organizations and certainly between our groups here. And so we want to provide an opportunity to actually listen, to hear what you're working with, what you're struggling with, for you to share out what you're doing in your organizations, and for us really to make sure that we have an opportunity to share in real time, in a real space. And so we're creating a space for this in partnership with the SAMHSA, or the SAMHSA Center of Integrated Health Solutions. You'll be getting invites for this, but you also have a preview link here on your screen. We'll be hosting a listening session next week on Tuesday, and you'll get the information for this, and also you have the link for it there on your screen. You're welcome to invite of course, your teams, other stakeholders in integrated care. And so we'd like to start with a poll, and we really just want to acknowledge that we're all in kind of strange situations right now. So curious, where are you calling in from or listening in from? Are you in your clinic? Are you in some sort of other type of office or administrative location? Are Are you at home, like many of us, and kind of functioning remotely? Are you at home and functioning, but in different ways? Maybe you're also taking care of loved ones, pets, other responsibilities at home. You know, maybe you have things going on in the background. I think we want to acknowledge that. Or maybe you're in a different situation. So let us know. We'll pull up the polling results in just a moment here. Okay, so let's see what our tally is. Okay, so interesting. So we have the majority of folks, 49%, who are at home and kind of otherwise working remotely and adapting to the situation. But we also have about 32% of folks who are in today still in the clinic, and I think that's important to acknowledge. And doubly, thank you for taking the time. We're really dedicated to making this time valuable for you. And then, of course, other people are adapting, and I see people using your chat box there in the bottom right. And so, as a note to that, we'll be encouraging interaction today. We'll have a time for questions and answers at the end. But please feel free to use that chat box to type in your thoughts, type in your questions, type in your reactions and what you're doing, and we'll go through those as we continue today. So I'll move us to our next slide here. Okay, so again, this is part of today's discussion is part of a broader 7-part series. It's our second, and really the whole point of this series is to look at taking a more integrated approach to diabetes, especially when we're talking about combined integrated behavioral health and primary care settings. We know that we have work to do to really improve screening and management for diabetes. We can maximize the values of our teams, but also we want everyone who's listening in to be able to really take what you're already doing, enhance it, even if it's just you, even if you don't have a full, large, robust team at your disposal, and also to work on some of the processes and procedures that are in place to make those more effective and efficient. So obviously today we're focusing on prescribing practices, but this is part of a broader series, and we're going to continue with these series that you should already have in your invite if you join today. So why are we talking about this? Well, just very briefly, we know that people with behavioral health conditions are less likely on a greater, just a huge difference, much less likely to be able to obtain care for diabetes and to get that regular care and management as well as screening for diabetes. And the flip side, we know that people who are getting treatment in primary care are less likely to have their behavioral health needs met. And so in a lot of ways, we're asking providers to do even more. But we know that behavioral health folks in particular are uniquely situated to really impact diabetes. We're experts in changing behavior and working with others. And more and more, we're going to be looking towards shared metrics where both primary care and behavioral health are working towards common goals. So no matter who you are, as Dr. Gibson talks to us today, we're going to be hearing about what's the role of psychiatrists, but also other people with prescribing privileges on an integrated care team. If you are a psychiatrist, perhaps new to integrated care, what are some things you should really be thinking about and doing in your practice? But then again, even if we're in settings that are small practices or you don't have access to a psychiatrist or you don't have many prescribers on your team, how can you take some of these ideas and really apply them to your day-to-day work? So with that, I want to introduce Dr. Patty Gibson. She's a psychiatrist and the Chief Medical Officer at Alleviant Health Centers. She's board certified in addiction medicine, psychiatry, and anesthesiology, which is such a critical intersection right now as we talk about pain, as we talk about opioids, as we talk about addiction. And again, she's a CMO, and she's also involved in national and state level initiatives, which I'll let her highlight. But one that we're particularly excited about is the Arkansas Behavioral Health Integration Network to kind of gather momentum for integrated care in the state. So without further ado, I want to turn over to Dr. Gibson. Dr. Gibson, thank you for taking time to be here today. We know that yourselves and other clinical leaders are really at capacity right now. So please take us away, and I'll defer to you.
Thanks, Andrew. It is exciting and a little bit nerve-wracking to be giving a presentation today. It's nice to be able to have some normalcy, to be able to be building toward the future and not just totally focused on the COVID situation that we have going on right now, but we can't help but not focus on it. The other nice thing about having this presentation today is that I think that we always need relationships and networking with each other, but crises like this definitely help us to, we need each other. And it's hard to get through it as a single clinician, and it's hard to get through it as a team of clinicians. And it brings really to the forefront what we're trying to do on a daily basis and how can we do it in a better way. So I'm grateful to be here. I've had a lot of opportunity to work with Andrew in some of our national behavioral health integration organizations and meetings. And I have learned so much through these national networks. And because in a way, when you're doing integrated behavioral health, in some ways you feel like you're on an island. It's like you're constantly having to explain what you're doing and what you should be doing and how you can work together. So definitely in our practice, we are trying to deal with how to continue our clinical care day to day. We're trying to think about our employees, our patients, how to make the connection with using telehealth, using face-to-face, and then continuing on how to keep our businesses going and to help everyone working in a good way. But I'm excited today to talk about what I've had the opportunity to do in my different roles as a psychiatrist in the VA and inpatient, outpatient, in substance abuse treatment, and then have an opportunity to be in an integrated behavioral health team as a psychiatrist team leader, and then being in a private hospital clinic setting where I was a director of a team hiring and supervising therapists of all sorts, and then in my new position as a chief medical officer and helping direct a company, but being back on the specialty mental health side and then trying to connect with primary care and other specialists and how can we become partners in patient care. So I'm excited to get to focus for a little bit on how we can continue to move forward and build our networks and connections. So I know that there's a poll that we want to see. How many people have a psychiatrist or other psychiatric prescriber on your team? And you can answer yes or no. And I know there's been some folks commenting in the chat box about what they have, whether that's a psychiatrist, a nurse practitioner, a physician's assistant. And once we have a few answer, we can see just where folks stand. So it looks like 60% or 75 people actually do have a psychiatrist or prescriber on their team, but 40% or at least 50 don't have a prescriber yet on their team. So hopefully this presentation will give you some ideas for the psychiatrists and the other prescribers, but also if you're looking for a psychiatrist or why you might. Next slide. What we hope to talk about is why would you have someone with psychiatric training on your team if you're in primary care or in specialty medical care? And then what would they do? How would they do it? And who would you hire? Because these are all important pieces. Next slide. I love showing this slide because it seems like as a psychiatrist, people often will immediately say, hey, I know you're analyzing me. And I'd like to wish that I was analyzing everyone as I'm speaking with them. But oftentimes, what I'm also fighting is that people call me a prescriber. And although prescribing medications is something I've spent a long time learning, I feel like I have a lot more to offer to my patients, whether it's an individual patient or a clinic of patients, but also to my coworkers, my team members, that I can do a lot more than prescribing. One of the things that's important, I guess, just to say is that to become a psychiatrist, you have to finish 4 years of college, 4 years of medical school, and then a psychiatry residency is 4 years, or if you're going to do child psychiatry, it's another 2 years. So psychiatrists are medical doctors, but it's been a long time since we might have been in clinical care, but we still have that training and that knowledge, and that is what we should apply as we're applying the psychological theories that we learned, but also in our care of patients. And in the topic today in dealing with diabetes, this is an extremely important knowledge to have. The other side of that, though, is to know that primary care providers and other specialists in medical school, you often get a month to 6 weeks traditionally of psychiatric training. When people go on to internal medicine or primary care, their residencies may only get about a month of formal training in psychiatry, and then they go on and mostly specialize in their family medicine or internal medicine. So there is kind of a fork in the road in medical training, and that happens in nursing and other medical careers, that people decide they're either going to be mental health or not mental health. And although that used to not be as much of an issue, it has become more that way, as especially primary care providers are being asked to take care of the whole person, to pay attention to the mental health care of their patients. Next slide. So this slide just is a map showing the gray are the parts of our country that have 0 psychiatrists. The dark green is where the largest percentage is, and you can see that most of those are out west and in California or up in New York and in that area. So there's not a lot of psychiatrists around the country. So even if you were to say, I want to hire a psychiatrist, it's going to be hard to find. Next slide. Everybody knows there's a shortage. 2001, the recruiters looking for physicians, psychiatry was a 13th specialty. In 2017, psychiatrists were the second most requested specialty needed. You see, we don't have many psychiatrists in the country, and a good many of us are over 55. And then those who are practicing are often not taking insurance. So there's a huge limitation of psychiatrists. Next slide. So the big issue is access to psychiatrists and access to other types of prescribers. So integrated care is as we become more focused on taking care of the whole person, all of a sudden we're saying, okay, we want more psychiatrists, we want more mental health providers, but they're not there. So we need to look at new models of how to practice or to get psychiatric support. It's not all in the traditional face-to-face, one-to-one visits. We also need to look at new ways to pay for psychiatric care, because often it's how things are paid for is what determines the type of care that we have. Next slide. So basically, education is one of the most important pieces of this. How can we transform having each individual psychiatrist or psychiatric prescriber to be able to spread their training and impact to more than one patient at a time? So simply going from giving a man a fish to teaching him how to fish. So we know that there's a huge place for education and teaching primary care providers and other types of specialists just on how to do assessments, what types of medications to prescribe. There's tools, there's ability perhaps to access a psychiatrist or other prescriber through e-consults or having someone in the clinic. We'll talk some more in a minute about psychiatric access lines, that you might have an ability to consult with a psychiatrist nationally or in a statewide. There are CME type conferences where primary care docs can get training in specialty in mental health care, because as I mentioned, they didn't get a lot of hands-on care about psychiatry in their residencies. Care coordination is all the more important. It's kind of obvious that doing work as a team would be most ideal care. But when it comes down to it, we really haven't been doing this traditionally. So we need to increase our ability to work as teams and for everybody to bring in their expertise. We're also needing to use more telepsychiatry, and this COVID crisis is helping us all to have more opportunity to do that. We're needing to do not just teaching, but looking at the really complex cases. And the ECHO model, I think a lot of people that's becoming a more common term, but the ECHO model of teaching that spreads it out from a hub and spokes training model. Next slide. So I wanted to go through a few cases that actually show, these are cases that I've personally been involved in that showed various ways that a psychiatrist might be involved in your clinical care and some of the things that we might do and expertise to bring in. But this is a case of the therapist was actually employed by me and was working co-located in a clinic. She called me about a 27-year-old male that had insulin-dependent diabetes, and she said he had an addiction to marijuana. And actually, it was synthetic THC. She said he'd been in the hospital recently and was in a coma related to lack of control of his diabetes. And he'd had multiple visits with her working on motivational interviewing and screening for brief interventions and trying to get him into treatment for his marijuana dependence. She initially called and said, I need help getting this patient into substance abuse treatment. And, but he keeps being turned down because it's just a marijuana dependence. And normally insurance companies do not pay for inpatient or residential treatment for marijuana dependence. The other thing is she was saying, I'm not sure what all is going on with this man's brain because he also has had a history of a traumatic brain injury. He was in a coma, and he's been using this synthetic THC. So she said, I'm not really sure how to make sense of his judgment or his choices about things. So we were seeing that there was some cognitive impairment, and we couldn't determine that on the spot as what the cause was, but it was going to impact his ability to participate in therapy, his ability to participate in treatment. And she said, well, what can we do for detox for this type of substance? So some of the things that I was looking at as a psychiatrist, number one was to back up and look at what is this patient's cognitive function, and does he have the ability to make choices and take care of himself? You can see where this would really make an important factor in terms of his being able to take care of his diabetes, much less his being able to make choices about using or not using the synthetic marijuana he's been using or any other substance. It would also affect his ability to get himself to treatment, to take other medications, or to be able to maintain some recovery. What we talked about is the importance of her communication as she's trying to get him into treatment, to let him know that this man has failed outpatient treatment and he has chronic serious medical illness that is going to mean he is going to need residential treatment. And the likelihood of him being able to succeed as an outpatient, he's more than what the case sounds when you say this is a young man who has an addiction to marijuana. He is at high risk actually for harming himself again unintentionally, if not intentionally, but also he's at high risk of not doing well because of the diabetes and the coma that he's already been in. There is no specific treatment for detoxing from marijuana generally, but there are medications that could be prescribed to help him cope with it and improve his opportunity to do well. The problem with marijuana alone, if you were to try to detox, is it takes so long to get out of your system that really it's not a check into the hospital or take some medication for 2 or 4 days anyway. So this patient is probably going to need some longer term support psychiatrically as well as substance abuse. He'd be a patient that you'd really want to look at what is his sleep function, what's his anxiety and depression, and he's going to need therapy in addition to substance abuse treatment. There are some antidepressants that we might consider using that could be beneficial to him in terms of his brain function, his substance use, and as well as his diabetes. But they're important to pay attention to. One would be mirtazapine, which is a great antidepressant, but it also can increase appetite, and that could be a major issue with someone who has diabetes. So I would be saying, well, what is his size and what is he looking like? The other great thing about mirtazapine is it can cause someone to be sedated so it can help them sleep. Bupropion or Wellbutrin can be a good choice in somebody who has substance dependence, even though it's not FDA indicated for treating substance dependence. It has been FDA indicated for treating smoking addiction. And so we found that like a lot of the medications in psychiatry, we use a lot of them off-label for similar issues that that may not have had the FDA testing. So the craving that's associated with any substance abuse, Wellbutrin could help. Benzodiazepines would be you'd really want to caution someone using benzos in a patient like this who has a substance abuse history, as well as a cognitive issues. So this is sounds like a very easy case, but could take a lot of teamwork and needs a lot of help for this young man to even survive, much less to do well. Next case. The next one was a case, a social worker who was employed by the primary care clinic, not employed by me, but we've had a relationship. And so she called me and said, hey, my doctor is seeing a patient right now. We're referring her to treatment, and she should be have an appointment in 2 or 3 days. But she is manic right now and has a history of bipolar disorder. And so my doctor wants to know, what medication recommendations could you give until she can get into outpatient treatment next week? So that brings up a lot of the issues. Bipolar disorder and diabetes is going to have a lot of comorbid things to think about, just in terms of trying to help the patient manage their diabetes and to do all the lifestyle factors that they need to do. Bipolar patients have a constant struggle in trying to keep themselves in a stable lifestyle. And they're usually going to need some medications if they're to the point of a patient like this who is manic in the office. I remember she was spending her money, she was gambling, and was being really hyperfunctional at work, but about to get to where she was not functioning well at work. Patients who are manic are a little bit easier for us in terms of knowing for sure what the diagnosis is. One of the biggest problems in treating bipolar disorder is that they usually don't present when they're manic. They'll often present to primary care when they are depressed. And when you're prescribing an antidepressant, it's going to be very important to know, could this patient be bipolar? Because if you prescribe an antidepressant, then they may trigger their mania. But this particular patient, it was pretty easy to kind of talk through what medications might be good to prescribe in the short term. Number one was starting with what was she on before and what has helped her before. However, the medications we might choose have a lot of side effects, in particular that could impact the diabetes. Specifically, although lithium is an awesome mood stabilizer, it can be difficult to take, and in someone that is not being consistent with their medications, it may not be a good choice. But if she was already on it, I might say, let's go ahead and take it. But you'd need to be looking at a lithium level and also know her other medical problems. Lamictal is often a great choice in mood stabilization if a patient is fairly stable, but it's not a good choice in someone who's manic and needs to have an effect right now. So we would look toward more of the other medications, which would include Depakote or the atypical antipsychotics. Unfortunately, both of those classes of meds can have issues with increased appetite, weight gain, and with the atypical psychotics, metabolic syndrome, which people who know diabetes probably know that more than I do, but in terms of increased blood sugar, increased ability for the body to deal with high blood sugars, and it's going to cause increased weight and increased blood sugar. So you end up having to do risk benefit, looking back and forth as far as what's going to be best for the patient. This particular patient, we ended up recommending, I think she ended up being prescribed Zyprexa because it could get her to sleep quickly and would help stabilize her mood quickly. Unfortunately, when she showed up in the clinic a few days later, she had not taken her medication. So that's always the risk there. Benzodiazepines, where normally I would not encourage use of them as much as we can avoid them. But in a patient who's manic, you're often needing to use some benzos to get them to sleep, as well as looking at some other sleep meds. And sometimes there is a place for antidepressants in a patient who's bipolar. And so in just being able to talk about this specific case to the primary care doc or to the therapist to really look at the chart and see what is she taking now. It's not a very easy case to just look at a medication algorithm and to really know what to do next. Next slide. These are just some of the things that we think about when we're doing psychiatric medication management. There's an art and a science to prescribing meds. It definitely can help to understand and almost to just have an algorithm of when they're anxious and depressed, you might lean to a certain class of meds. When they're really lethargic and depressed, then you might lean to another. But we also look at all of these other factors that can complicate the situation and what you would prescribe, depending on how sick the patient is. So it's like in a lot of things we deal with in medicine or in behavioral health, it would be levels of what's the patient's function and how well are they doing. And so a lot of things can be managed at the most basic level, and having a psychiatrist or a other prescriber, nurse practitioner, physician's assistant available could help you look through some of the different factors when a patient is not getting better with initial treatment interventions. You will always need to make sure that the psychiatric disorder is accurately diagnosed, and then specifically what are the symptoms that they have. One depression is not the same as another depression, depending on some are more anxious, some are lethargic, some are very hyper, some are so mental health providers probably can talk more about that than I can, but it's not a one size fits all. The physical health problems very much can impact the way that we would treat and what medications that we might use or try to avoid medications. We'd want to look at what are the other medications a patient is on and how these can impact and interact with each other. Just this morning, one of my nurse practitioners was talking about a patient was on tizanidine and another heart medication. But when they asked us about, they just said, well, can we refill the tizanidine without letting us know that they were on other heart medications? And these interactions can be extremely bad. So unfortunately, the silos in medicine where primary care or other medical specialists kind of say, well, I'm not taking care of mental health, so I don't want to know about those meds. And unfortunately, a lot of psychiatrists and mental health people, we just want to look at our psych meds without looking at the others. And these are extremely important to do a good job in knowing what all medication someone's on. It's crucial to know if somebody has substance abuse and whether or not they may abuse some of the meds that you're on, that you're prescribing. I've already talked about the importance of benzos and how bupropion might help with that, but we're learning more about how patients might abuse gabapentin or Seroquel. Patients often will use anything that can make them feel mood altered. A huge thing that people can look at is sleep. People sleeping too much or not enough. And sleep apnea is one of the most undiagnosed disorders that cause psychiatric issues. And especially if you're trying to treat someone who has diabetes, if they are not getting good sleep and good oxygenation and good recovery all night, it's going to be hard for them it's going to be hard to control their diabetes, as well as it's going to cause a lot of cognitive issues, irritability, depression. So this is an area that we often are not really assessing well. Even primary care docs or cardiologists or any other type of specialist. We tend to just look at one part of the patient instead of all parts. In psychiatric management of patients, you all know better than I do that the social situation is extremely important in how well a patient's going to do, and to whether or not they are employed, what's their relationship situation, where they living, can they even afford the meds that we're trying to prescribe. And I put side effects in all caps because the research that has to do with the evidence for specific psychiatric medications, basically, if you look across the board at any class, say the antidepressants, basically you can't say that one antidepressant is more effective than the other. They all can have similar effectiveness, but in different types of patients. When we're looking at prescribing psychiatric medications, we are usually looking at kind of balancing the side effects that these medications might cause. Like earlier I said, mirtazapine can cause increased appetite, increased weight gain, and increased sedation. Well, that can be a really useful side effects to use when you often have, especially in elderly, but not always elderly, you may have patients who are very depressed, they've lost their appetite, they're losing weight, and they can't sleep. So mirtazapine can be a really useful medication to use, but you're using it mostly based on the side effects as well as the pharmacology of the medication. Next slide. This is a case that is one of my favorite cases. It didn't start out my favorite because it took a little while, but this is a case where I was on a team with a primary care doctor, a pharmacist, a care coordinator, RN, and a care coordinator social worker. And after a while, this team was actually meeting every week to discuss their complex cases. And this patient, I can't remember how long he had had diabetes, but he was supposed to be taking insulin, and he just would not take his insulin. And it took different people on the team talking with the patient to really figure out that him understanding what he was supposed to take, but also figuring out where was his anxiety about taking the medicine and what was it related to what the meaning of insulin meant to him, as well as just his fear of taking shots. So it took some real creativity in seeing the people on this team work together to find a solution that would get this patient to be able to take his medication and then eventually change his lifestyle. I think he actually ended up not having to take insulin long term. But it was a really rewarding, it took several weeks and months of different people working with this patient to help him to be able to change his life, to be able to manage his diabetes and his other health issues. Next slide. So those three cases are three examples of showing different places or roles of a psychiatrist who could work with a team, either face-to-face with a team, could be someone who's hired with the team, who is someone who is not actually on that team or even working with that company, but could collaborate and having collaborative relationships and connections. This slide shows it's a common cartoon that we're seeing these days from the University of Washington, the AIMS program, and there's a link to that site that shows the patient is the center of the team, and you have the medical provider and the behavioral health care manager who are working directly with either remotely or on site with the primary care doctor, and that the patient is the center of the team and directing. And you can see the solid lines where the patient behavioral health consultant are communicating, but the psychiatrist may be communicating intermittently with the primary care doc or the patient, but the psychiatrist and the behavioral care manager are communicating weekly through a discussion of a registry of patients. There are codes for now for the collaborative care management model, and we hope those will continue to be used because there's good, strong evidence that shows that this model can make a difference in decreasing depression as well as improving other medical issues. The registry is a huge part of the success of this program, and so I'll just circle that of being one important factor of the success of this type of program, tracking patients and how well they're doing. But I have also been involved with teams that we did a hybrid type of program using these pieces to the team, but then also using other parts, more of a blended model of having some co-located behavioral health, primary care behavioral health consultants. Next slide. This is a slide talking about several types of education that psychiatrists could be involved in uh, to help teach people to fish so that everyone can practice at a higher level of competence in terms of managing mental health conditions in primary care or in other medical specialties. Um, there's a lot of education that can happen at discussing cases. What I found in working with my primary care doctors is that the first few questions they asked me, I was kind of like, okay, that's great. I felt really pleased that I could help them with very little effort on my part, but they learned, and in medicine, we're often learning from the cases and the patients that we have. And so the questions that they ask me get harder and harder and harder. But that shows that there is learning happening. And so this can be in a very formal way, either as patients come up in their schedules. You can plan to have either scheduled weekly, biweekly, or monthly, either one-to-one plan to discuss cases, or perhaps have a group of people. It could be in person or via webinars. There can be formal webinars like this. The ECHO model, where there's actually a organized hub of training with a schedule, there are some programs that are existing, and you can access that link. In Arkansas, our University of Arkansas Medical Sciences, we've had an ECHO program going. I'll give you the link there. They had a grant, and the ECHO program is specifically about using medication-assisted treatment for opioid dependence. And then the REACH Institute I've put on there that I've had an opportunity to participate in is a program that provides training for primary care physicians, and also there's one for child pediatricians and teaching them about managing mental health issues with children. And these consist of a weekend of CME, but the best effect of the training is in the case conference calls that happen for the next 6 weeks after that, or 6 to 12 weeks after the weekend. That's when we really can see more and more change and training for the primary care docs. Next slide. This, I refer to this state and national child psychiatry access program. Massachusetts is very well developed. And what this consists of a model where there is a place or some people who are providing a psychiatrist and perhaps social workers a phone number and a connection where primary care clinics can call this number and be able to get information about what type of treatment a patient might need, how to access various treatment options around their area, or for physician-to-physician conversation about specific questions they may have about the particular patients. So I think this really may be part of the answer to our issues with access and lack of access to psychiatrists in the country. Next slide. I love this slide that Dr. Rainey has created that shows the whole spectrum of how technology can be involved in behavioral health care. And you see it's only really telepsychiatry at the far right, where a psychiatrist may be doing one-to-one, either seeing a patient one-to-one, but there's also this asynchronous model where perhaps you might interview the patient in your clinic, make a video, and then that is the psychiatrist might look at that at another time and be able to give you kind of an e-consult or a phone call where the patient isn't having to get on the psychiatrist's schedule. But you can see it goes anywhere from the least level of interaction with patients using their own management, their own apps, text messaging, and then up to having capacity for access to psychiatrists or other specialists through embedded in the electronic medical record, e-consults, ECHO, etc. Next slide. This may be my most important slide for the whole, for you to take a look at, is that the psychiatric provider that you want to hire or train, there are certain characteristics that are going to make a psychiatrist or nurse practitioner or PA better for this type of integrated behavioral health work. And And I would say this also applies to therapists or counselors or psychologists who are going to work in integrated care. This is a very different type of traditional work than what we were trained in. It takes somebody who, and there's been evidence and research that's shown which programs have which types of psychiatrists, but somebody that's willing to be very flexible, that doesn't mind problems coming up, who can be adaptable, who is able to be interrupted, and who is able to deal with liability concerns. And because we're not used to having to just give our opinion without knowing much. Somebody that likes to teach and enjoys being part of a team and willing to lead. So there are some resources on the American Psychiatric Association website that has modules for psychiatrists to learn how to be involved in an integrated care team. So I think this is a huge part. I think a lot of times administrators or clinics will often hire a person, whether it's either a social worker or a psychiatrist, and say, well, we hired one, but it didn't work out. This integrated care model is not working. It's like a lot of things. You have to have a good match of the workers with the work. And so this is a huge, important piece. If you don't have a psychiatrist, it's going to be important to find the right one, or at least be someone that's willing to train. Next slide. So that's the end of my specific presentation, but I know there may be questions, and what are your thoughts, Andrew?
Yeah, thanks, Dr. Gibson. So some folks have already been entering questions into the chat box, and please continue to do so. And while people are entering more questions, Chaim, if you could just advance to the next slide. There's a couple of resources that Dr. Gibson shared. First, I just want to highlight that the SAMHSA Center of Excellence for Integrated Health Solutions, again, this is part of a series co-hosted with them, but there's also echoes and other learning communities available specific to integration there on those links that we've shared, and also free training technical assistance available if folks have questions. And if you go one more slide over, sorry, two more, and we'll come back to this one. Dr. Gibson, did you want to just walk us through a couple of the resources?
Yeah. So the AIMS Center has some great resources on actual lists of medications, and those can be really great handouts to have. And then they have a job description for psychiatrists who would be working on a team, and then a training model on the AIMS site, as well as one on the American Psychiatric Association. Great. Next slide, I think. And then here's some very good, Dr. Rainey has done a lot of great work in teaching a lot of us about integrated care. And so you can see the SAMHSA site, and there's some YouTube videos, and then the American Psychiatric Association has a whole section on integrated care that's accessible to anyone. I think that.
So, and you know, I think I saw some in the chat, and I just echo, you know, particularly your last slide there on selecting the right psychiatrist or, you know, other member of the care team, and that flexibility point was echoed by others. But, you know, also I had that same experience as a psychologist who's worked in primary care, and I've worked with lots of psychiatrists as well as nurse practitioners, psychiatric nurse practitioners, other provider types. Where we don't see success is exactly what you described, where we have someone who's sort of sitting in a room somewhere with the door closed, and they said, you know, do not disturb, or, you know, just, you know, send me an email or something like that. If they don't have that integrated team spirit, it really breaks down even the best training, the best availability of resources. Suddenly people don't pick up the phone to talk to them or knock on their door. So, you know, finding the right fit, I'm so glad that you mentioned that.
Mm-hmm. Mm-hmm.
So we can get into a few of the questions that have come through. One of the earliest questions was around one of the case examples that Dr. Gibson that you made or presented rather, specifically around medication adherence, around working with patients, not only around psychiatric medications, but they're, you know, taking insulin and other medications related to diabetes. How do you kind of have conversations with them to navigate that?
Yeah, that's huge. And there are a couple of short books about medication adherence, or there may be some articles, But I would say some of the tips would be, you really want to find out, using motivational interviewing approach, what is important to the patient. No one's going to take a medication or do anything if you just give them the order. So you have to understand what's important to them and make sure that they understand what the medication's role is. But also, a lot of times people don't understand that there is a meaning to taking medication. And so if you tell me I'm going to have to take this medicine for 10 days, that's one thing. But what does this mean that you're now giving me insulin? And so it's really important, like a lot of good, I think, mental health assessments, is look at the whole person in their whole context, their context of their life before, and what does this mean? And then do they understand what they need to do? And then what could be the barriers getting in the way? Sometimes it's something as simple as financial or transportation, or they're not going to choose to buy their own medicine when they're spending their money for their children or their parents or something else. So I would say the key is finding out what's behind it in a very non-accusatory way.
Yeah, I love that point. I often, even as someone who wasn't prescribing in primary care, but was supporting others, starting conversations and following up after one of my patients met with their PCP or psychiatry or anyone else around a medication or pharmacy, and just starting the question of, okay, I see that you're being prescribed this. Is there anything that you're afraid of, or is there anything that you feel you don't know? But rather than starting with just, okay, do you have any questions? No, good, right? And so I think there's, and you've highlighted a number of these. There's these opportunities for, even those of us who are trying, we're not necessarily trying to prescribe or get out of our scope, to really support those prescribing practices.
Yeah.
We have
I think
a few
you made a
questions.
good point to say about out of your scope. A lot of times people will avoid even saying the word medicine. They will say, well, I can't talk about Prozac because I don't know anything about it. But I think it's almost unethical not to ask what medicine someone's on and whether or not they're taking it. And if you learn a little bit about side effects, then you can help navigate that, or at least communicate back instead of doing the whole avoidance thing. So sometimes we go overboard and we call it scope of practice, and it's not common sense.
100%. I think even, I like that idea of even just asking what questions, they may be having, or if they're having any issues, we're a lot of us are trying to navigate into telehealth right now, but even before that, our healthcare systems are so large and complicated, even in rural areas where it just may be separate clinics. It's hard for our patients to navigate that. And so if they're having an issue with one medication, and adding to your point, we should be asking them about psychiatric medications, and of course their diabetes medications and other things too that may be within our sort of traditional discussions, but helping them get connected, relaying those questions, sometimes that makes such a big difference. So we have a few other questions that have come in. Specifically, I think a number of people mentioned, some of them have psychiatry consultants, some of them the PCPs, the general practitioners, the family docs, the kind of the primary care practitioner is really the solo provider of any sort of medication. Any additional resources for those folks who don't necessarily have access to a psychiatrist, but just in general, maybe clinical practice guidelines or anything like that? And something I sometimes have thought about is are specifically the VA and DoD have put out clinical practice guidelines, sometimes around medications for depression, anxiety. They also have one on diabetes. I don't know if you've seen anything decent in there.
And I'm wondering, are you asking, are the physicians looking for clinical guidelines, or are the clinic managers or clinical guidelines for who to do what, I guess?
And we're looking for the physicians who are working, perhaps who are new to integrated behavioral health, for example, and now they're managing both behavioral health and diabetes. Where do they go for information?
Yeah, I think that's a great answer. Yeah, the VA and DoD have some great, and you might be able to share that link to the excellent. And the AIMS website has a lot of tools that like those medication guidelines that I sent, and I think that's a good single resource.
Yeah, I'm going to post that into our chat as well. So other questions that people have also submitted. how do we know when, so for many folks who do have a consulting psychiatrist, either remotely or they're in the clinic, how do you know when to bring them in? Are there certain questions that we can ask with our patients to kind of facilitate that information sharing?
One thing is I would encourage you to get to know your consultant a little bit to understand, because everybody is going to have different levels of comfort. It's just like my therapist didn't want to bother me too soon about the young man who had a marijuana addiction. And as soon as I heard it, I was like, oh my gosh, this young man actually could die because he had just come out of a coma. So she was trying to take care of a lot and not bother me too soon. So I would say that one of the best things is get some cases that you already know that you need some help, and have some discussion, and you'll get a sense. And to not be afraid or intimidated to ask them, well, what type of patients do you want to call me about? Because usually consultants are very happy to talk to you, and they want to be part of it. That's why we love being part of a team and feeling like we can make a difference for you and for your patients.
Yeah, great point. And some folks in the audience have really echoed that. And one of our attendees mentioned that, they often, they're sort of conduit for community. They'll have patients who express concerns to them as the behavioral health clinician within the team that they haven't necessarily mentioned to the physician or the person who's issuing prescriptions. And I think that's a great point. It's so interesting, and really for all of us, when we work in integrated care teams, the things that we hear about the other members of the care team, and how we choose to interpret that sort of communication is up for discussion. But yeah, I mean, and I think that goes for everybody, right? When we're working alongside, and one of our upcoming sessions will be on nutrition. And so whether you're the nutritionist, you're the social worker, psychologist, you're the psychiatrist, the PCP, the nurse, we all tend to get a slightly different piece of the pie.
Yeah.
Let's see, what else have we got here? So some folks talking about in value-based payment or value-based care, sometimes a disconnect where if we think of that integrated team, and if you have the primary care provider in the center, they're trying to decide, hey, when do I refer to psychiatry? When do I refer to the psychologist or social worker or counselor? Any tips on how to make that? Because what we often see is they just kind of, on old habits, they just send everyone to psychiatry, and then we're back to the same backlogs we had before we integrated care.
Right. And I think that's a thing of continuing to build teams that, number one, you can go in either direction of too far. You might say, well, only refer the patients that need medications to the psychiatrist or the prescriber. Well, one of the things, like I said, we can do a lot more than being prescriber. It may be some of the best thing we can tell you is a management type of situation, not necessarily what medication to prescribe. Oftentimes you can figure out what medication to prescribe and what the dose is. So that's one thing, is don't wait too late to involve the expertise. But also definitely don't think that everything needs to go through psychiatry. So it's just really going to depend on the team and the individual comfort level. So I know I'm saying yes and no, but a lot of it does boil down to the particular people. But I guess I would encourage everyone to learn case by case basis, everyone to learn as much as they can, and not think, well, that's a mental health concern, that's not mine, or that's a medications concern, that's not mine, or people who prescribe shouldn't say, well, that's a therapy thing, that's not mine.
Right. Yeah, absolutely. That kind of no wrong door approach. And later in our 7-part series here, we'll be talking about developing workflows and clinical pathways, including for diabetes. And it is so important to figure out, well, when do we make these decisions? Who goes to who? And really kind of whittle away at that pest behavior of just boom, boom, boom. Everyone goes to the same source, and oh gosh, they have a 6-month wait. Well, that's just how it goes.
Yeah.
Part of integrated care, I think we all know, is really increasing access, making everyone on the team accessible, and also as a team then kind of chipping away at that tendency to just bombard one type of professional. Dr. Gibson, I've heard you talk about the future of psychiatry, and I think you've really highlighted what, from my experience, a lot of psychiatrists also comment on, that, the role is more than, prescribing, right? Um, and also the role is expanding, and prescribing is expanding too, to different provider types. Some of the audience members have mentioned physician assistants with a focus on psychiatry, and others, we know psychologists are sometimes prescribing in certain states, in DoD and other places it's even more common. Um, what do you think about the role of others in this? And then we'll make that our last question here.
Mm-hmm. Yeah, that's a complicated question depending on where you are and where you're coming from. I know that my answer has changed over the years of being in practice. Because initially I would have been like, oh no, I went to med school. No one else can prescribe. But I think we all have different backgrounds and different trainings. And the important thing is to try to keep yourself as educated as you can. I love working with nurse practitioners and PAs and psychologists and social workers and non-licensed mental health providers. So I think there's a role for it. I think we need to be careful to not think it's so easy. Like when I said, well, anybody can get the book on how to prescribe or can go to Hippocrates and go, well, this is what you do. The art of when to use what. So that's where the team, and so any particular individual or training, you could have an awesome psychologist or physician's assistant who gets the big picture, who would be a great person to be the actual one prescribing. But you can also get a terrible psychiatrist who should know the whole story, but is not looking at the whole picture and prescribe something that may not be what someone else would use. So I don't think it's something you can say is all or nothing, but that we're going to have to continue to expand our different roles and to make sure people are trained and to practice the highest level of what the evidence is.
Absolutely. And I think this is what we're talking about in the entire series, and integration is getting everyone to the highest level of practice. We know that patients are better in that sense. We're more satisfied as clinical staff and administrators and everyone when we can really operate at the kind of top of our levels respectively. So we're at time, and we're actually a minute or so over. Thanks everyone for sticking around, and thank you, Dr. Gibson, for presenting. Thank you to everyone who's joined us, especially amongst everything that's going on right now. I pasted again the link in there for our discussion next week on an open forum for integrated care stakeholders, clinicians, and others to join us in this open discussion. Thank you to the National Council for Behavioral Health, the home of the SAMHSA Center for Integrated Health Solutions, to Primary Care Development Corporation, where again you can find a host of other resources, and we'll keep chatting about this. And everyone who's doing the work, thank you all. We're gonna get through this. And a big part of how we're going to do that is by coming together and integrating services.
Thank you. Any final words?
I think folks are filing out, and we're just about to close down our webinar here, and we'll come back on in just a moment.